I'd like to introduce Jose's coming in. Jose, can you click to turn off your video? That way it won't rob bandwidth, and we'll mute your microphone. There we go. There's a little button there that to stop video, or that you can click on, Jose. There you go. Excellent. Good. Looks like we have a good group. Benjamin's here. Jennifer. Chandler, you need to kill your video as well. The reason we're doing that is to try to keep from robbing bandwidth for those of you that may have lower bandwidths. It'll keep this going. I'd like to introduce you guys to Dr. Matthew Eschelbach. Dr. Eschelbach, of course, is one of our medical directors, and he is the medical director up in Oregon at St. Charles Health System. He teaches quite regularly, I believe, for EMS services and others, and is an ER physician up there, as you can see. And his lectures are always extremely eye-opening for us, because he also teaches, you know, in the conference circuit and I believe in other settings. So if you give Dr. Eschelbach your undivided attention, I'm going to mute my microphone and y'all have a good time.
All right. Good evening. So we're going to talk tonight about what I'll call the fifth vital sign, and that's end-tidal CO2. So we know we work with heart rate, blood pressure, temperature, respirations, and then O2 saturation. And then I'm going to combine with O2 saturation is end-tidal CO2. So by the time we finish this lecture, we'll have a good understanding of what end-tidal CO2 is. And up until a few years ago, the best that we could do to confirm intubation was to actually watch the cord go through the cords and monitor CO2 confirmation with a colorimetric changer, or suction devices that gave us indirect information. So here are the three ways that we used to do it in the past. These two here, these two suction devices, if you were in the esophagus and you had a hollow tube inside a hollow tube, you could use this large 60 gauge or a 60 cc catheter, pull back on it, and it was form fitted for the end of the intubation tube. And if you got no resistance at all, then you were in the trachea. This suction device, when you press on it and let go, if it was in the trachea, it would fill. If it was in the esophagus, the walls would stick to it and it would not fill. And that was about the best you could do with blind intubation. And then we have this end-tidal CO2 cap that we still use after intubation. And it would let us know colorimetrically if we were exposing the patient to oxygen or CO2. And when CO2 was absent, when the patient was breathing in oxygen, it would be purple. And when it was breathing out, there would be yellow. And then what the problem that paramedics faced was not so much the yellow and the purple, that was easy, but this brown area here. And this brown area happened when we were coding a patient. Perhaps they were intubated, there was no spontaneous circulation, and we would get this kind of a dirty brown color, and people said, well, what do I do with this? And why do I even have this device? And it's evolved over time. So now, keep in mind that the only continuous source of CO2 production is cellular respiration, which has to happen when we have a live person with vitalized organs. It's the gold standard to measure end-tidal CO2. And by watching the waveforms, it's all part of the devices that we use commonly, whether we have a Zoll or whatever device we have. Colorimetric change devices can be used in the field as a quick and dirty way of knowing that we're in the correct place and watching CO2 changing back and forth until we get a good definitive waveform. I still use these CO2 colorimetric devices. It's just part of ways that I go. I will intubate. I'll usually use a video glide scope watch it pass through the cords, hook it up, make sure I've got the good color change, and then move forward. But this is the, we're going to talk tonight about capnography. And we're going to learn a little bit about the science behind capnography. And by the time we're done, you'll be able to recognize all types of forms of capnographs. Let's go back to our basic science. Keep in mind that humans are all mammals, breathe in oxygen, and as a byproduct, we spit out CO2. Now, the nice symbiosis is that we give that CO2 to the trees use and make sugars, and through photosynthesis, they give us oxygen back. And that's just part of the chain that we're in. Cellular respiration happens when we have live tissues, live beating heart, breathing lungs, and what happens is you break down glucose, you combine oxygen. Through cellular respiration, we give off CO2 and water vapor, and then energy, which powers the cells. And we'll go over this in a few seconds. So this is how we look at the entire scheme of oxygenation and ventilation. Our pulse ox is measuring oxygenation. How much oxygen is sitting on those red blood cells? Cellular metabolism is what's happening as we burn up oxygen and produce CO2. And both of these end run eventually wind up in the lungs, and that's how we measure capnography. So let's keep in mind, here we have a beating lung right here, and a beating heart and a breathing lung. And we take in oxygen, and it goes into our alveoli. Our alveoli then diffuse it to our capillaries, and our red blood cells go into the capillaries, where it's perfused to our muscles. And then we get cellular respiration and breakdown of glycolysis. Oxygen is utilized and CO2 is produced. And then the metabolism of the CO2 goes through the vein, back to the lungs, back to the alveoli, and then we breathe it out. That geographically can be seen in the capnogram, which we will go over and you'll understand entirely by the time we're done. So what can affect CO2 levels? Well, muscular activity, cardiac output, certain drugs or bronchospasm can increase CO2, and then hypoventilation or trapping of end byproducts can cause an increase in CO2. Decreased CO2 will be seen in increased or decreased muscular activity, a decreased cardiac output, bronchospasm, and hyperventilation. So what's the difference between oximetry and capnography? A pulse ox measures oxygenation. 92, 93, 94, 95%. We aim for high pulse ox levels when we're treating somebody or adding supplemental oxygen. Capnography measures the ventilation and gives us a geographical and graphical waveform available for interpretation. O2 or SpO2, our pulse ox, is non-invasive. It measures the percentage of oxygen in the red blood cells. Changes in ventilation can take minutes, up to 5 minutes, to be detected. So there's also an effect of artifact, poor perfusion, and certain dysrhythmias. This is our pulse ox, which, as we know, in certain older people or children, etc., that we don't always get a good reading, and there can be some variability. Keep in mind that this information is up to 5 minutes old. So if we were to stop somebody's oxygen and wait, it might take 5 minutes for this pulse ox waveform to give us a true reading of what's going on. Keep in mind that when we talk about colorimetric, this is the colorimetric change that we were talking about when we see CO2 in a colorimetric changer. That is different than waveform technology. Ventilation, measured in partial pressure of mercury or percent volume of CO2 in the airway at the end of exhalation. And I'll show you exactly what that means in a few moments. It varies from breath to breath, and it provides information within seconds. Therefore, we don't have the lag time of up to 5 minutes that we might have with pulse oximetry. And it's not affected by motion artifact, poor perfusion, or dysrhythmias. So we have 2 different ways of measuring this. The side stream technology is the one that is most prevalent. And if we have an intubated patient, we have the side stream port here. Or if we have a simple nasal cannula with side stream technology, we can measure it that way. And we get a capnography waveform. And we'll spend the next few minutes talking about how those waveforms are reflected. So in summation, oxygenation is for metabolism. You measure the percent of oxygen, and it reflects changes that can take up to 5 minutes. Ventilation, or CO2 metabolism in end-tidal CO2, is measured at the point of exhalation and reflects a ventilation change that's reflected every 10 seconds. Our low-flow side stream technology is the one that's most common. You get immediate information about your ABCs, your airway, breathing, circulation, and you get a printed form of documentation. I'll show you about that in a few minutes. So what's going on with end-tidal CO2? Remember, we've got blood coming in from the right ventricle. It comes in through the pulmonary artery, where it drops off CO2 at the alveoli. Through ventilation, oxygen's coming in, oxygen jumps onto the capillaries and goes onto the pulmonary vein and into the left atrium. And what that gives us is a waveform that looks like this. This is a normal capnogram, and what we will do is break this into each of its components and discuss each component. All right. So those waveforms, you'll get to know them as normal or spontaneous ventilations. We'll talk about hyperventilation and hypoventilation, and then we'll talk about some specific ones like bronchospasm, which will lead us to the shark fin, or the curare cleft when our muscle relaxants are wearing off. We'll talk about that a little bit. And then we'll go in a little bit into cardiac oscillations, which we won't spend a whole lot of time on. Here's the normal capnographic waveform. And each cycle, each breath has a beginning, a middle, a plateau, an end expiration, and then a recycle. So phase 1, let's talk about dead space. What is dead space? Keep in mind that all of the business that's happening with capillaries is happening down at the alveoli and lung level. But there is gas that's in your nose and in your equipment that we don't measure. And this is known as dead space. No gas exchange is occurring, and it's essentially a dead space. Where is the dead space? Anatomically, it's at the top of the airway. There is alveolar dead space if there are areas that are ventilated, but they're not necessarily giving us a good gas exchange. And there's mechanical dead space. That's the air inside of our ventilation equipment. So let's begin with the capnogram at phase 1. Right here is the beginning of exhalation. We've got a baseline level, and keep in mind that you breathe in, and as you breathe in oxygen, you exchange all that oxygen for CO2, and then you breathe out. Right here, the beginning of B is the beginning of your exhalation. What's going on in that is the CO2 from the alveoli, which are in your lungs, begins to reach the upper airway and mix with the dead space, and that causes a rapid rise in CO2. CO2 is now present, and we can measure it with our device. So this ascending phase is when we're breathing out. CO2 is present in the exhaled air. Phase 3, the CO2-rich alveoli gas now constitutes the majority of the exhaled air, and our CO2 becomes a maximum. And that's the plateau phase. So we begin exhalation. As we exhale, CO2 goes up. We reach an alveolar plateau, and then we reach our end tidal CO2. So end of exhalation contains the highest concentration of CO2, or the end tidal CO2. Tidal refers to a breath, tidal breath. The numbers seen on your monitor normally will be between 35 and 45 millimeters of mercury, right there. So when we see the number that says end tidal CO2, it's this number right there. So oxygen goes in, CO2 goes out, and we can measure it in a normal capnogram. For terminology, a capnogram is a waveform recorded with a concentration of CO2, and a capnograph is a waveform plus the numerical value. I'll show you a capnograph in a few minutes. End tidal CO2 is the measurement of the exhaled CO2 at the very end of your breath. And again, the normal range, 35 to 45. Why do we have a normal range? Well, because when we start talking about hypoventilation or hyperventilation, we'll see how these numbers change in disease states. Phase 4 is the descending phase. That's when you begin to take a breath in. And when you breathe in, what are you breathing in? You're breathing in oxygen. So as oxygen fills up the airway, the CO2 quickly drops to 0, and there's our descending phase. And now we're ready to take, this is our breathing in. We're ready to go for our next inhalation phase when we drop off more CO2. Here's our normal capnograph. Increase in CO2 over time, and we wind up with a normal capnograph. End of inspiration, beginning of expiration and exhalation, a plateau. D is our end tidal CO2, and we begin a new breath in, and our CO2 goes down. That's a normal waveform. And this is what it would look like. So a capnograph will have a number, a respiratory rate, and a visual representation, just like an EKG that you can print out. Normal range, 35 to 45. What happens if we breathe too quickly? Well, that's pretty easy. We've got a normal range. If we breathe too quickly, we're breathing too fast, what happens to our CO2 level? It drops. It not only drops, we'll measure it, so it'll go down here. Instead of being 35, it might be 30. And you can see by going too fast, our little normal breathing is now about 2 to 1. So for every 1, 2, 3 breaths now, 1, 2, 3, 4, 5, 6 breaths. When is there decreased CO2? It'll indicate hyperventilation, decreased CO2 deficiency will show hyperventilation, or decreased pulmonary perfusion. We might see that in a disease state of the lungs, hypothermia, or decrease in metabolism. What are the interventions to correct this? Adjust the ventilation rate, slow it down. Evaluate for adequate sedation. Is the patient anxious? If they're anxious, they're going to breathe too quickly. And you're going to conserve body heat. What happens if a normal patient without any oxygen on begins to breathe too quickly? If they're anxious and they breathe too fast. What happens here is you breathe too fast, you blow your CO2 off, therefore you decrease your CO2, and then the patient begins to hyperventilate and they get carpal pedal spasms of their hands and tingling around their mouth. And how do we tell them to correct that? Well, we tell them to slow their breathing down. We might have to give them some Ativan or something, or we give them a paper bag to breathe into. That's the same way to rebreathe that oxygen and increase the CO2. So how would your capnogram look if you intentionally decreased your respiratory rate from 16 to 8? How would it look in frequency, duration, height, and shape? Well, that's what happens with hypoventilation. In our last hyperventilation, we had about 2 to 1. Now we've got 1 to 2. So rather than having 4 breaths or 16 per minute, we're now slowing that down. What happens when we do that? When we don't breathe fast enough, this is normal, we see our CO2 creep up, and our end tidal CO2 goes up to about 50, maybe more. So above normal, hypoventilation could happen with respiratory depressant drugs. That happens when we give somebody narcotics, right? Or perhaps an increase in metabolism. Interventions, adjust the ventilation rate, speed it up. Maybe decrease respiratory depressant drug dosages. We might have to give Narcan or something like that. And make sure we maintain normal body temperature. So now we've discussed 3 waveforms: normal, hyperventilation, and hypoventilation. There you go. Okay, now we're going to use capnography and ask this question. How would the waveform and shape look during an asthma attack? Now I'm going to put in parentheses asthma attack, COPD exacerbation. Bronchospasm waveform hampers ventilation. The alveoli unevenly fill on inspiration, and they empty asynchronously during expiration. So because you have an asynchronous filling and emptying, you have a change in the flow of CO2. That alters the ascending phase and the plateau phase, and you get a slow rise in CO2 and a characteristic shark fin waveform. So bronchospasm looks like this. Keep in mind, CO2 might be normal if it's plain asthma. If this was a bad COPD exacerbation, this number might go up to 50 or 55 or even 60 if it's a bad COPD. So now we've got 4 waveforms. Asthmatic waveforms have the typical shark fin appearance. COPD patients have a difficult time exhaling gases, and this is also represented with a shark fin appearance. You'll see our asthmatic is at the upper limits of CO2. Our COPDers will tend to be here and higher. So we can look at a mild attack where our end-tidal CO2 might be 28 and our respirations are 38, or the moderate attack where our numbers are climbing, or a severe attack, and you'll see that our respiration rate goes down, and as our respiration rate goes down, our CO2 goes up. What's happening here is the inefficient and incomplete exchange of gases leading to that shark fin appearance. Time to get moving, time to figure out what to do. So what's happening is air trapped due to irregularities in the airways and uneven gas exchange dilutes the exhaled CO2, and you get a slower rise in CO2 concentration, leading you to the shark fin deformity. It produces change in the ascending phase in 2, and you get an upslope, and it alters the plateau, leaving you with the shark fin deformity. So there's normal, and there's bronchospasm. So here we are. We have a cheerleader who has an asthma attack. You're called to the gym. You begin a treatment. Initially, your waveform looks like the typical shark. And then as you treat her, you'll start getting more normalization. So you can see a visual representation that your therapy is helping. COPD is very progressive. Keep in mind in COPD, what's happening down here at the alveoli level is you're really getting an increase in mucus production rather than just plain alveolar mismatch. You get increase in the mucus glands and the smooth muscle, excess mucus production, and hyperresponsiveness of the airways. If you were to measure the arterial CO2, you would see that the arterial CO2 also increases in this disease process. Some COPDers walk around with blood CO2 levels that are normally around 50. And as they start to get closer to an exchange of 50% CO2 and 50% oxygen, when we measure those arterial levels, that's when we start thinking, is this person tiring and do I need to intubate this person? So here is another COPD person. See that his CO2 is way up here. He's got the shark fin appearance. We begin a treatment. We listen to his lungs. We treat again, and we get him closer down to the 45. We can also see changes with congestive heart failure. Take this patient, 88-year-old male, complaining of shortness of breath. History of MI, on oxygen, usually 2 liters per minute. Pulse of 66, their blood pressure is elevated. The respirations are increased and labored. They've got cool and diaphoretic skin. They've got 2+ pedal edema, and their initial oxygen saturations are about 69%, and tidal CO2, 17. Let's just look at the numbers. Pulse, not too bad. Blood pressure, elevated. Respirations are high, which means that's why they're blowing off some of their CO2. But we also see that they have saturations that are low and 2+ pedal edema. Excuse me. So what do we do with these patients? We place a non-rebreather mask on to increase their oxygenation, 15 liters per minute. Our protocols call for nitroglycerin in these patients, and then 10 minutes after treatment, their O2 saturations are up to 99%, and tidal CO2 is closer to normal. And if we look at this capnograph over time, you can see that slowly the CO2 starts correcting and the waveforms look more normal. We can also use capnography to titrate end-tidal CO2 in patients who are sensitive to fluctuations in their brain. For example, patients with head trauma, stroke, brain tumors, or brain infections. Let's talk a little bit about what happens with the circulation in the brain when we talk about CO2 and oxygen. High levels of CO2 will induce cerebral vasodilation. So inside the vessels of the brain, as we increase CO2, the vessels dilate. This has a positive effect by increasing the cerebral blood flow to counter cerebral hypoxia. So if your body is not, and your brain doesn't have enough oxygen, this is what naturally will happen. The negative effect is this increased cerebral blood flow also causes brain edema. Hypoventilation retains CO2 and it will increase CO2 levels. Low CO2 levels lead to cerebral vasoconstriction. The vessels constrict. The positive effect of this, at around 30 to 35, will cause mild cerebral vasoconstriction, which will decrease intracranial pressure. Keep in mind that the decreased intracranial pressure may also lead to some hypoxia. So it's a teeter-totter. We're at a very fine line of too much pressure, too much oxygen, not enough CO2, too much CO2. So hyperventilation decreases CO2 levels. Decreasing CO2 levels will lead to vasoconstriction and decreased intracranial pressure. So our treatment goals are to avoid hypoxia by monitoring the blood oxygen, give as much oxygen as possible, but try and target the end-tidal CO2 to 35. So when would that occur? When we have a head injured patient. So we get to the scene, we suspect that somebody has a fractured skull. We notice that they're at high risk for head trauma and maybe their Glasgow coma score is 8 and we decide to intubate this patient. Then by artificially giving them as much oxygen as possible while slowing their breathing down to increase CO2, we're going to help the brain and the swelling. Head injured patients, by titrating their CO2 to 30 to 35, can help the untoward effects of the increased intracranial pressure that's going to happen with brain swelling. Titration is not hyperventilation. Remember, intubating a head injured patient and using capnography gives a means to closely elevate CO2 or monitor CO2 levels. You want to keep them between 30 and 35. All right, we're going to move on to the intubated patient. Obviously, we have somebody intubated, and now, up until this point, and the head injured patient, we've been talking about using side stream technology with a nasal cannula. Now, we're going to intubate the patient and use the side stream technology on an intubated patient. First thing is confirmation of placement of a tube. So if we're rolling along and our CO2 level is low, and then we get the tube in, the CO2 is going to shoot up high and we start to get a waveform. That's easy. So, no waveform, no tube. There's simply no better way to confirm proper tube placement than to see the waveform of capnography, period. No waveform, no tube. The opposite effect is what happens when we have a tube in, we watch it go in, we confirm it, we know we've got a good waveform, we load the patient in the ambulance, and then we lose the waveform. What happened then? Well, the tube backed out. We got to start over again and go back in and re-intubate that patient so we can watch this. Before end-tidal CO2, we didn't know this was happening. So we'd have somebody with a good intubation, we'd load them in, and then if the tube backed out into the hypopharyngeal area, we could essentially kill that patient on the ride to the hospital by having improper placement. That's why end-tidal CO2 is so important with an intubated patient. Only capnography can give you that true end-tidal CO2. Keep in mind, go back one, remember, oh, well, I'll pick it up with the O2 saturation. Well, let's say we've got an O2 saturation of 92%. It's going to be 5 minutes before we get a good reading, and all of a sudden our O2 saturations are down to 70. So if we have a continuous line, and all of a sudden we lose our line, we know that we've lost our tube. It's that easy. Here's the documentation we talked about. Capnography provides documentation that, let's say we hand that patient off, which very often happens, and in the process of putting that patient from the ground onto your stretcher, putting them in the ambulance, riding them to the hospital, and then transferring them from your stretcher onto the stretcher in the ER, somewhere in between, that tube comes out. Let's say it comes out when you're in the hospital and the ER physician says, you intubated the esophagus. Look, you pull out your piece of paper and go, no, I've got good end-tidal CO2 all the way until you took the patient over. So it happened here, not way back here. Can we use capnography during CPR? You bet. It is the best assessment, along with chest compressions, for early return of ROSC. This guy is working hard on CPR. This guy has intubated the patient, and then we're looking at side stream technology. He's going to continue CPR, and we're not going to know if our interventions made any difference until we start looking at the end-tidal CO2. For example, he's rolling along, and then slowly, we get some increase, and then now we start to get a waveform, and boom, our waveform goes up, and we've got ROSC. So we briefly stop CPR, we check for an organized rhythm, and now we know we can stop our CPR because we've got a good waveform with end-tidal CO2. Why is this so high? Well, there was a lot of buildup of CO2. So as we're moving along and exchanging with CPR, when we finally get return of spontaneous circulation, there's a lot of CO2 to offload. So the Kaplan graph of an intubated cardiac arrest patient is a direct correlation of their cardiac output. Increase in CO2 during CPR will be an early indicator of ROSC. It also tells us a few other things, unfortunately. If we continuously monitor end-tidal CO2 and we've got ranges from 4 to 10, chances are most non-survivors fall into that area, where most survivors will wind up with an end-tidal CO2 average of greater than 30. So we want to make sure that we continue our CO2, and our goal is to get return of spontaneous circulation and our end-tidal CO2 greater than 30. It may also point to resuscitation. Some of you call in and say, I've been, I'll get a call from an agency. Patient's intubated, we've done CPR for 30 minutes. We've had a PEA rhythm, we've had an asystole rhythm, we've had no spontaneous return to circulation. Can we call the code? And I'll say, what's your end-tidal CO2? And they'll say 12. And I'll say, how long has it been there? 30 minutes. You can call the code. Remember, non-survivors, less than 10. Survivors, surviving to discharge, usually greater than 30. So in hypoventilation states, we're also going to find out that there's some ways of thinking about sedation, maybe alcohol or drug intoxication, stroke, CNS infections, and head injuries, and then abnormal breathing, end-tidal CO2s, in CO2 retention. Those are our COPD patients. Hypoventilation stasis, again, here's our hypoventilation, long blocks, and high end-tidal CO2s. And they're going to look like this over time. Capnography reflects changes in perfusion. For example, maybe pulmonary blood flow is low, systemic perfusion could be low, or cardiac output could be low. All of these will show low perfusion states. So here's the case scenario. We have a 57-year-old male who's in a motor vehicle crash with injury to his chest. He has a history of AFib. He's on anticoagulants. He's unresponsive. His pulse is 100. It's irregular. Blood pressure is 88 over palp, and he's intubated on scene. And he's got low end-tidal CO2, which is probably a reflection of low cardiac output. Maybe he's got injury to his heart. Maybe he's got injury to his lungs. But we have good measure, and we know we've got good waveforms. Or somebody might have a pulmonary embolus and they've got a good strong radial pulse, and low end-tidal CO2 might be seen in somebody who's having a PE because they're not able to give you a good exchange of gas. And lastly, we can get elevated baseline here, and that might be an indication of poor neck alignment. We might also get a clue to a diagnosis in somebody who's in DKA. What happens in diabetic ketoacidosis is they are hyperventilating because they're trying to blow off their CO2, because the A of DKA is acidosis. And by trying to blow off their CO2, the CO2 goes up, their body's trying to compensate for that. So we might do a finger stick blood sugar of greater than 400 and notice that we have a high end-tidal CO2, which would lead us to believe that we have a patient who's got diabetic ketoacidosis. A few troubleshooting. If we get things that are sharp and then look like this, what's happening here is we're getting an inadequate seal, and maybe we've got a problem with our ET tube and we have to change the cuff. Or we might have irregular, almost shark fin, but we're not hearing wheezes. That might mean that we've got partial obstruction, and we might need to suction out the tube and make sure we don't have mucus or something else stuck inside the tube. And when we don't go all the way down to baseline, when here's our end-tidal CO2, and when we don't go down to baseline or 0, it does not touch the baseline. This indicates a patient who's rebreathing and they have insufficient inspiratory or expiratory flow. So we might think that they might need bronchodilators, for example. All right, so in our last few minutes, we're going to take a quiz. What is this? You go from a good waveform to no waveform at all, and your CO2 goes down to 0. Well, this one's pretty easy. Sudden loss of waveform, apnea, airway obstruction, esophageal intubation or dislodgement. Airway can become disconnected, or maybe your side port came undone, or there's a problem with your malfunction. Check the pulse. Maybe they're in cardiac arrest. All right, over time, we've got good waveform, and over time, we're starting to build up CO2. What's happening? Increase end-tidal CO2, hypoventilation, decrease in tidal volume, increase in metabolic rate, or maybe a rapid rise in temperature, hyperthermia. All right, we've got a waveform and then we don't. That's an esophageal tube. A normal capnogram is the best evidence that the end-tidal CO2 has been, and the tube is placed correctly. With an esophageal tube, we get little or no CO2. All right, here we go. Creeping up over time. It looks like this, trend-wise. And that's the rebreathing. Could be a problem with the valves in our equipment, or the patient has air trapping. They might have a pneumothorax. All right, we're doing this, and then over time, it changes. Some kind of inadequate seal, leaky or deflated endotracheal tube, artificial airway might be too small. And then over time, slowly downtrending, decrease in end-tidal CO2, hyperventilation, increase in tidal volume, a decrease in the metabolic rate, or a fall in body temperature. Now we go from normal to shark fin. That's obstruction. Remember, obstruction could be something in the tube, or it could be obstruction down at the alveolar level, like COPD or asthma. It could be a foreign body, or a break in the circuit, or bronchospasm. And this is that little cleft that we saw. If we have all of a sudden start to see this, let's say we intubated a patient, we gave them succinylcholine, and they're moving along fine, and then we start to see this cleft. That's called the curare cleft from muscle relaxants wearing off. So it might be time to switch to something longer like rocuronium to keep the patient unconscious longer. All right, that's the end of our lecture, the end of our discussion, and I'll take any questions.
Let's just start one at a time. This gives me an opportunity to see if everybody's here too. Keith Becker, have you got anything for Dr. Eschelbach? And just undo your mic.
No, I think it was a great section on the troubleshooting. I think that was a great refresher trying to figure out what's going on with the tube and as well as with the patient. So I have no question. Thank you.
Thank you, Keith.
Thanks, Keith. How about you, Jose? Jose, all you got to do is click on the little microphone to unmute yourself. We need to know you're still here.
Yeah, sorry, I was talking, but it wasn't mute. Yeah, no, I have no questions. I enjoyed the lecture, and you know, I did have a couple of questions on the end title, but you know, the doctor actually cleared a lot of those questions that I had.
Okay.
Excellent. All right. How about you, Dylan?
I do have one quick question. So it would be, I'm sure you went over it, but I was also researching at the same time the stuff that you're talking about. So whenever you have a patient, let's say they have pulmonary edema, you know, wouldn't they become acidotic like in their metabolism, but there would be no exchange, therefore the end-tidal CO2 would actually, you know, be decreased, right? Like you would get a lower reading, a lower end-tidal CO2 reading with your capnography and all that. That was my question as far as what would
somebody with pulmonary edema would be somebody like CHF, and that person would give us the pattern where we'd see a decrease in perfusion. So let's see if I can go back quickly to one where we had that exact scenario. Hold on. And it would look like this. And, you know, over time, somebody who had bad perfusion, their end-tidal CO2 will be low because they're breathing fast and their SATs are bad. So we give them oxygen, we give them some sublingual nitroglycerin. Maybe we put, positive pressure ventilation on them. And then over time, it's going to creep back to normal. So pulmonary edema and CHF are going to behave the same.
All right, that answers my question. Thank you.
All right.
Perfect. All right, Mike, your turn.
Great. I actually had two questions. Really appreciate it. This is fantastic content. The first one is, I know out here in Denver, they've started to use eye gels a lot in the field in hopes of trying to prevent having to go full blown into endotracheal intubations. And I'm assuming that the end tidal would be pretty similar with those, but are there any major differences that you would note between full intubation and something like an eye gel or laryngeal mask?
Well, keep in mind that an eye gel is a supraglottic airway and it's not complete control of the airway.
Right.
The only thing that I could say is just assuming that the side stream technology would be the same, you're going to see maybe a little air leakage around the end of the end-tidal CO, along the eye gel, a little air leakage. So your waveform may change a little bit, but in general, the physiology is going to be the same.
Okay. And then the other question I had, I was really interested in particular on the titrating the end-tidal CO2 for trauma patients. I imagine that it'd be probably different for each patient that you're dealing with, but is there kind of a general rule of thumb as to how long you'd be looking for that titration to take effect with somebody that has, let's say, like a closed skull fracture or something like that?
Well, what you're going to do is you're not going to make these changes quickly.
Okay.
They're going to happen over 20, 30 minutes. And the best way that I can explain this is I had a patient who was a pediatric patient who had a sudden increase in intracranial pressure from something called normal pressure hydrocephalus. They could no longer maintain their airway and I had to intubate them. I intubated them because they had irregular pupils and they were starting to show signs of a blown pupil. So once I intubated them, I blew that patient down to about 30 millimeters of mercury, and over about 20 minutes, the pupil normalized. So it's going to take time, and then you're going to aim for that 30 to 35, and you're going to have to go a little faster, go a little slower, and just take your time. And then it's going to take about 25 to 30 minutes to see an effective change. Okay. And sorry to hog the mic here, but with something like that, are you using a BVM to titrate that more effectively, or would that be something with a ventilator that you're using in that case? Well, most of you are going to have bag valve mass in the field, and you're going to have to just slowly titrate it. If you can get them on most of the time, you don't have access to a ventilator unless you're transporting from one hospital to another. So you're going to do it with a BVM most of the time. Okay. Great. Thank you.
All right, Chandler, it's your turn.
Yeah, hi. I have one question. I don't know if I missed it. It was on the QRA cleft. What is the actual reason they get that dip towards the end of the waveform?
They get that dip in the waveform because the muscles are starting to slowly increase. And anytime that you get, like here is an obstructive pattern from bronchospasm, and in a curare cleft, you're getting a little bit of asynchronous distribution, and it gives you that little hitch in the giddy up, is what I'll call it. And there we go, right there. And then it's a little bit of an obstruction-like, but incomplete relaxation of the airway muscles, and you get a very temporary decrease in the CO2 concentration. Okay. What you do if you see this is you go, oh, okay, I've intubated with succinylcholine. It's been 10 minutes since I gave succinylcholine. I'm 10 minutes from the hospital. I'm going to give them some rock uronium so that they have a more smooth muscle relaxation, and I can hand them off to the doctor with a normal capnogram.
Okay, makes sense.
All right, Luis.
Sorry, I had trouble there unmuting. So I think my question kind of went with Michael's earlier. I think I wrote down when we have a high increase of CO2 as far as relating to head trauma, how the effect would be towards, I guess, brain perfusion, and I guess time frame as well for us, since, you know, I guess there's kind of minimally of what we can do for treatment in the field for that.
Well, keep in mind that if you had a GCS, Glasgow Coma score, less than 8, that person needs a tube.
Okay.
If they're awake and alert and you know that they've taken a head injury, maybe they've starred the windshield, you put them in the ambulance, and then you start to notice halfway to the hospital, let's say it's a 30-minute ride to the hospital, now they're starting to become less awake, less aware, and they're showing signs of slowing. Two things could be going on. It could be their head injury or something else. If their GCS gets less than 8, they need a tube.
Okay.
And you tube them, and then you make sure that their pupil response is okay. And then assuming that they have a known head injury, you're going to keep that CO2 lower, 30 to 35.
Okay. And at that point, we're increasing, I guess, O2 sats for them as well with high flow oxygen.
Right.
Gotcha. All right. Yeah, that was it. Thank you.
Good questions, by the way. Jennifer, your turn. Jennifer Taylor, are you here? There you are.
Yes, I'm here. I'm sorry. I couldn't find the button. Thank you. I have no questions.
Okay. Benjamin.
I have no questions either. Thank you for the info, sir.
And last but not least, Marilyn.
No questions. Thank you so much for the excellent lecture.
Awesome, sir. Thank you very much for tonight. Folks, I'm going to try to get this downloaded and posted in case you need to go back to it to refer to it later. Dr. Eschelbach, thank you again for being patient with us tonight.
All right, you're welcome. Take care.
All right, I'm going to close the meeting. Thanks all. Good night.
Good night.